Leiomyomas, or also known as fibroids, are benign growths of the female uterus and the most common tumor of the female pelvis. They occur when cells within the uterus are genetically different to the other cells in the uterine cavity that come together to form a mass called a fibroid. Most women tend to experience some form of fibroids which may have symptoms or be asymptomatic. The cause of fibroids is unknown, although it is thought to be associated with estrogen levels. The three different categories of fibroids can be determined by the location in which they grow. Subserosal fibroids grow outside of the uterus wall. Intramural fibroids grow within the walls of the uterus and are the most common type. Submucosal fibroids grow underneath the inner lining of the uterus and can also protrude into the uterine cavity. They are the rarest type of fibroids. Although the direct cause of fibroids are not known, it has been found that genetic mutation plays a part in about 70% of cases. The presence of high levels of female sex hormones, estrogen and progesterone, cause the fibroids to grow, which is why leiomyomas are most commonly seen in women of reproductive age. The risk factor of women who can get fibroids is higher when women are between the ages of 30 to 40. Fibroids can also be hereditary, occurring between mother and daughter or sisters. Women who are of African descent are more likely to get fibroids, often beginning at a younger age compared to white or Asian women. Diet can also be a contributing factor, including excessive consumption of alcohol. Too much meat and processed foods can lead to fibroid production, as well as too little fruit and vegetables. Being overweight or obese or having polycystic ovarian syndrome can also cause fibroids. Symptoms of this disease include heavy, prolonged, or irregular periods with a possibility of blood clots. Dysmenorrhea and dyspareunia are often prevalent amongst the symptoms. Increased urination and increased menstrual cramps may also be indicative of a fibroids diagnosis. Miscarriage and infertility may also be a result of this. Doctors will often ask about family history, period length, period pain, or any previous surgeries. They may also ask about the pregnancy history, including gravidity and parietal numbers, as well as number of miscarriages. Both transabdominal and transvaginal scans will often be completed when there is a suspected case of fibroids. Both scans can aid in diagnosis in different ways, as transabdominal scans can give a general overview of the pelvis region, and the transvaginal scans are much closer to the reproductive organs and are able to provide a closer image. Transabdominal scans for fibroids will include the sonographer scanning the uterus, endometrium, cervix, ovaries, fallopian tubes, adnexae, and also the kidneys. The transvaginal scan will include all of the listed, excluding the kidneys.
A standard pelvic ultrasound comprises both of a transabdominal and a transvaginal exam. It is suggested to have both forms of exam, as a transabdominal will give a broader view of the pelvic region and may pick up pathology outside the scope of the transvaginal probe, but the transvaginal exam will give more detailed images. In some cases, vaginal exam is inappropriate, and if this is the case, the abdominal scan can be sufficient. Informed consent is also important for both exams, and with the transvaginal exam often requiring written consent. A transabdominal exam is performed from the anterior skin surface of the abdominopelvic cavity. To effectively complete the exam, the patient must have a full bladder and be laying supine for easy access to the cavity. A low-frequency curvilinear probe will be selected, as this will provide increased penetration through the cavity to the uterus. To begin a transabdominal scan, place the probe longitudinally at the midline in the suprapubic region. The uterus should be clearly posterior to the urinary bladder. Scan out laterally all the way past the organ and back through the other side. Do this twice, looking first for contour and again for content. Observe for any echotexture abnormalities throughout the organ. Then turn the probe into a transverse orientation and scan inferiorly to superiorly, completely through the vagina and the fundus. Complete this twice for contouring content, and then move out laterally to the adnexal structures and repeat. As mentioned earlier, informed consent for both types of scans is important, and as a transvaginal is an invasive procedure, in many cases written consent is also required. Patient preparation for a transvaginal scan requires an empty bladder and for the patients to be lying supine with legs abducted and knees flexed. A pad or cushion can be placed under the bottom and to raise the hips, allowing for better access, and a high-frequency transvaginal probe is used. When the probe is inserted, the image should show a probe cervix interface at the top of the screen. In a longitudinal position, scan by moving the handle of the probe to the left and right, observing for any abnormalities. Once 2 surveys have been completed, turn the probe in a transverse orientation. The transverse scan is achieved by lifting the handle towards and away from the bed. Always remember to complete your full surveys. A fibroid appears as a well-defined hypoechoic mass in the uterus, but they can also range from anechoic all the way through to hyperechoic. The internal characteristics show a heterogeneous, as there may be necrosis or hemorrhage within them. There can be a single fibroid present or multiple fibroids in different areas of the myometrium, and at times calcification can be present. When using Doppler, a low velocity flow can be seen, and this tends to be in the peripheries of the mass.
Fibroids being one of the most common benign tumours of the female genital tract, there are numerous surgical options which are selected specifically for each individual case and severity. For women who have yet to have children or who wish to preserve their uterus, the options are a hysteroscopic myomectomy, a laparoscopy, or a laparotomy. However, the only definitive solution to fibroids is a total hysterectomy. A hysteroscopic myomectomy is removal of fibroids without taking any healthy tissue. This procedure is done by inserting a small thin scope into the vagina through the cervix, which then reaches the uterus. A laparoscopy is the removal of fibroids via several small incisions through the abdomen. This surgery has a relatively fast recovery rate. A laparotomy is the removal of fibroids via the abdomen. This surgery is predominantly similar to a laparoscopy. However, it is a more invasive surgery and requires one large incision rather than several small ones. Because of this larger incision, it has a longer recovery time. There are many non-surgical options which are available to women these days, such as natural remedies, vitamins, prescriptions and/or over-the-counter medication, monitoring through regular ultrasound scans. There are also minimally invasive procedures which are offered, such as percutaneous laser ablation, transvaginal uterine artery occlusion, magnetic resonance imaging guided focused ultrasound therapy, and cryoablation. Many of these minimally invasive non-surgical treatments are still under investigation and testing. Most of these non-surgical interventions are to help reduce size or manage the symptoms presented with thyroids. Fibroids are a very common pathology amongst women these days, whether it is unknown to the individual or not. Research is constantly improving, giving a higher success rate to management and treatment.